All right, the subcommittee will return to order, please.
A recovering Oxycontin addict. So,
And I thank the staff for being so quick and switching the panels over.
but I'm not going
On our third panel, as you can see, we've got 7 witnesses. As I introduce them all at once, first is Phil Bauer, surviving father of Mark Bauer. Phil serves on the Parent Advisory Board for the Partnership for a Drug-Free America. Our next witnesses are Kathy and Courtney Creighton, surviving mother and sister of Ryan Creighton. Kathy is also founder of Mothers Against Prescription Drug Abuse, and I'm blessed and lucky enough to call them my own constituents. Also testifying will be April Rivero, surviving mother of Joey Rivero and founder of the National Coalition Against Prescription Drug Abuse. Our next panelist is Dan Harrison, who overcame a prescription drug addiction to gain custody of his children. He is a drug court graduate and also a constituent of mine. And finally, we are pleased to have Dr. Carol Boyd and Dr. Amelia Aria, who are widely respected nationally for their insight into addiction. On a personal note, staff told me to say what I already said about how proud I am to have some constituents on this panel. So welcome to each and every one of you. I really appreciate your being here. If you can see the timer boxes down there, it's just like a traffic light, green, yellow, and red. You know what they mean. The total time you're allotted will be 5 minutes each. So we are now going to recognize Phil Bauer for 5 minutes. And, oh yeah, slight little problem. Would you please slide the microphone down to Mr. Bauer?
Is that good?
Yes, thank you.
Good morning, Chairman Bono Mack, Ranking Member Butterfield, and members of the subcommittee. My name is Phil Bauer, and I'm from York, Pennsylvania, and I'm here today speaking as a dad. If you were to ask any parent what their biggest fear in life is, their worst nightmare, most would tell you it'd be losing a child. We are living that nightmare, and it's worse than we ever could have imagined. Our youngest son, Mark, died from prescription drugs. His death was preventable and avoidable, and I believe the underlying cause was ignorance, my ignorance. Of all the things I worried about as a dad, abusive medicine wasn't among them. Unfortunately, there are many people who continue to underestimate the dangers of abusing prescription drugs, and as I know all too well, ignorance can be fatal. On June 4th, 2004, my wife Cookie and I, along with our oldest son Brian, attended the high school graduation of our youngest son Mark. As you know, there are many emotions that come with graduation, and it is a significant milestone and accomplishment in a young person's life. And the emotions are not just for the graduate, but for their families as well. Pride, happiness, relief, fear, sadness. It is a transition in life, and some refer to it as the beginning. The words I would use to describe our emotions at Mark's graduation are devastation, emptiness, and confusion. It marked the end of our son's life. I can remember so well sitting there and staring at an empty chair where Mark should have been sitting, with his cap and gown draped over the back of the chair and his yearbook and diploma laying on the seat. But Mark wasn't there. On May 28, 2004, on what would have been his last day of high school, just 1 week before graduation, Mark died. That morning, I responded to my wife's screams and went to see what was wrong, and she said she couldn't wake Mark up. I started CPR, and Cookie called 911. When the emergency personnel arrived, we followed the ambulance to the hospital, were escorted to the little room, and we heard the words that our son was dead. We went back to see him to try to say our goodbyes, and we cried on his lifeless body. And for Cookie and I, life as we knew it ended that day. In his room that morning, we found a clear plastic bag of loose pills. They weren't his, nor did they belong to anyone else in our family. There were 7 different types of pills in the bag, 119 pills in all. When the toxicology report came back 3 months later, it was consistent with what we found in the bag in his room. Mark died from a lethal mix of oxycodone, acetaminophen, morphine, and stimulants. Just to give you a little background of my family, when our sons were born, they became the focal point of our life. Their mom quit work and became a stay-at-home mom, and she has been a terrific mom. To me, being their dad has been the most rewarding and important part of my life. I was a diaper-changing, bath-giving, story-reading, full-service dad. I took them everywhere I went, diaper bag and all, and we were together constantly. Throughout the school years, our sons never came home to an empty house. Mark was quiet and an introvert. He didn't let many people into his life. You had to bring him into yours. When people took the time to know him, they found a wonderful, caring person. Never much for words, he had a terrific sense of humor and could make you laugh just by his expressions and mannerisms. He loved sports, especially basketball, and was an avid weightlifter from the time he was 11. In the latter stages of his life, Mark was 5'9", 175 pounds. He could dunk a basketball and bench press 400 pounds. Besides sports, he loved his family, friends, the Outer Banks of North Carolina, puppies, Star Wars, playing video games, any Leslie Nielsen movie, shopping with his mom, and making fun of his dad. One thing we will never know is why Mark chose to take these pills. We don't know if he was abusing prescription drugs to get high, or self-medicate, or to self-regulate. We also don't know if he had an addiction problem that went undetected, or if this was just an opportunity that presented itself. I know now that abuse of medicine can lead to the same dependence and addiction as that of illicit drugs. They can also be lethal on the first use, especially if mixed with other substances. Unfortunately, there are still many people who underestimate the dangers of abusing prescription drugs. They believe that abusing these medicines is safer than using illicit drugs, yet it's causing more deaths in our country than heroin and cocaine combined, and filling up our treatment centers. Based on the numbers from the CDC, on an average day in the United States, 31 people will die from prescription painkillers alone. From the motivation and inspiration that I draw from Mark's life and death, I have dedicated myself to do anything possible to raise awareness about prescription drug abuse. I have learned so much about this issue over the past several years and have had many mentors. My journey has included forging partnerships with organizations and agencies which share my passion and commitment to combat this issue. I am pleased and grateful to have the opportunity to now serve on the Parent Advisory Board of the partnership at drugfree.org and to help promote and support their wonderful tools for parents. I have also had many opportunities to speak on this topic at national conferences, to law enforcement, to healthcare professionals, to community groups, and parent groups throughout Pennsylvania, and to high school students. I plan to continue these efforts as long as I am able. Abuse and misuse of prescription drugs is devastating too many families, causing crime and other social issues, filling our treatment centers, and killing too many of our children. There is no way to tell someone what it's like to lose a child. You either know what it's like or you don't, and I truly hope you don't. I am committed to do anything I can to help others avoid the devastation that Cookie and I live with every day.
Mr. Rivera, I'm sorry, if you could wrap up your minute over.
Today, I'd just like to offer my assistance to this subcommittee if there's anything at all I can do to support or promote your efforts to combat this public health crisis. Thank you.
Thank you very much. Ms. Creighton, you're recognized for 5 minutes.
Thank you. Good morning, everyone. Thank you, Chairman Bono Mack. I am so grateful to be here today, and I hope that my testimony provides valuable information that will help bring awareness about the epidemic of prescription drug abuse and diversion we currently face in our nation. My story is about the most severe consequences of abusing prescription drugs. I lost my son Ryan on September 4th, 2009 to an overdose of OxyContin. He was just 21 years old, and I agreed to come here today because I know there are thousands of families who are struggling with the pain of this situation just like I am. I sit here before you today on behalf of all of us and hope for some victory. My daughter Courtney is here with me today, available to answer any questions after my testimony. So I just wanted to say that I fought relentlessly to save Ryan's life, but when addiction is present, it's like spinning your wheels to try to keep up with their compulsive behavior. I believe the science that says addiction is a disease, that addiction is a disease and it's not a moral failure. As my written testimony details, my son was easily able to obtain these medications from doctors. He didn't get his pills from my medicine cabinet. Once I realized he was getting medication through prescriptions and not on the streets, I thought I could stop it. He was an adult by this time, and HIPAA privacy laws made it difficult for me to communicate my concerns to the doctor about him abusing pills to his doctors, but that did not stop me. I was able to get my foot in the door more than once. However, my concerns were mostly ignored, and Ryan still continued to receive OxyContin many times for something as simple as a backache. In some cases, even when doctors stopped prescribing OxyContin, they still prescribed other narcotics that a person with a history of drug addiction should never have had. In the last 13 months of Ryan's life, I documented 7 pages of medical records for visits to doctors, urgent care, and emergency rooms. There were 6 near-death overdoses that always resulted in a 911 call and hospitalizations, once for 8 days in a lockdown facility. It was a life or death struggle for Ryan many times, and we lived in fear. I saw my son's addiction progress rapidly once he became addicted to OxyContin. I believe that was the result of the aggressive off-label marketing practices of Purdue Pharma. He was never a candidate to receive such a powerful addictive narcotic, and I feel he might be alive today if he had not discovered OxyContin. He made several attempts to get off the powerful opiate OxyContin, but did not make it longer than 30 to 90 days at a time. After my son's death, I had the opportunity to discuss all the careless mistakes made by the HMO that provided his care. I was told in that meeting that they were not aware of the dangers of OxyContin at the time my son was receiving it. They were told it was safer than other pain medications, including methadone, morphine, and fentanyl. That confirmed everything I had read regarding lawsuits and Purdue Pharma, and now my family was a victim of their misleading practices. In general, Kaiser Permanente, which was the HMO in our county, claims it was not aware of the abuse of prescription drugs taking place among our youth. I was quite surprised hearing that, because I thought that if I knew, surely they should have known. I then realized how important it was to figure out a way to bring awareness of the situation to the medical community as well. I believe that this lack of understanding contributed to my son's death. In addition to the fact that they continued prescribing him narcotics after they knew he was an addict, I feel that prescription education is so important. Ryan's addiction to OxyContin resulted in a felony conviction for altering a prescription at a pharmacy. He was obtaining prescriptions from many sources at the time. That could have been averted if a prescription monitoring program was in place. Some of those drugs ended up on the streets. Ryan basically became a drug dealer to support his addiction to OxyContin. It was unbearable to see what was happening to my son, at what lengths addiction will take a person to. So in closing, I would like to say I will not stop fighting for my son in his memory. As a result, I have joined with some others to create an organization to fight this epidemic. Our goal is to make a difference and to try to save lives by bringing awareness to as many people as possible. So I appeal to those of you in this room today from the bottom of my heart to help me make a difference. I thank you all so much for being here, and I would like to request that each of you reach out to other members of Congress, your colleagues, friends, and family to spread the word about this epidemic. And please be open-minded and learn all you can. Together we can make a difference. Thank you.
Thank you. And Courtney, I appreciate your being here to take questions at the end if we have them, but we will go to Ms. Rivero for your 5 minutes of questioning.
Testing, 1, 2, 3. Okay, Chairman Bono Mack and Ranking Member Butterfield and members of the subcommittee, thank you so much for having me here today. On December 18th, 2009, just a week before Christmas, my husband and I received the devastating and inconceivable news from a Tempe Police Department detective that our youngest son, Joey Rivero, had been found dead by friends in his apartment off campus near Arizona State University, where he attended college. Over the next few days, as we worked to get his body returned home to California where we live, and funeral arrangements made so that we could bury him the day after Christmas, a story began to unfold that we were completely stunned by. We learned that Joey had been invited by a couple of students from ASU that he knew to travel with them on a 6-hour journey from Arizona to Rowland Heights, California, on December 9th, which was just 9 days earlier than his death, to visit a doctor who was well known for freely prescribing narcotic medications. All 3 students walked into this doctor's office together after the 6-hour drive, and they all walked out a short time later with prescriptions in hand. Joey's prescriptions, first time she had ever seen him, and after just a $75 payment to her, cash, and an x-ray that showed no problems in hand for him, was prescribed 90 30-milligram tablets of oxycodone, 90 350-milligram tablets of Soma, and 32-milligram tablets of Xanax. He and his friends were directed to a specific pharmacy that was at least 35 miles away from this doctor's office. They drove there together, and all of them had their prescriptions filled with absolutely no questions asked. We've since learned that both the doctor and the pharmacy had been under investigation for at least 2.5 years before Joey died. The DEA has since revoked her registration. The medical board has moved to revoke her license, and that's in progress. And criminal prosecution is expected for Joey's death, among several others, for this doctor. Joey had never been previously treated for any of the medications that were cited in his medical record by the doctor as the basis for the prescriptions that he received that day. And there's absolutely no indication that she counseled him on how dangerous these medications could be if they were misused or abused, especially with alcohol. So again, just 9 days after he saw her, he was dead. And that was after partying with friends in a college, a typical college setting. Wee hours into the morning, Joey went to sleep and he simply didn't wake up. The coroner's report indicated that he died from low levels of Xanax and moderate levels of oxycodone mixed with alcohol. His level of alcohol was .013. So he didn't have huge amounts in his system. The medical examiner indicated that none of the individual ingredients were lethal, but all of them in combination were. So it was the polymix that was a problem. Joey was due home for winter break the day after he died, and the Christmas we expected to share with him never happened. Instead, we somehow managed to get through the most awful week of our lives. Stunned, shocked, and grieving, we picked out a gravesite, coffins, and clothes for Joey to be buried in. I had to write an obituary for a young man who had not had time to develop the lifetime achievements that he should have been able to cite. Through it all, we struggled to understand how this could have happened to him, how our perfectly normal family could have been dealt such a blow. There really are no words that can adequately describe what my husband and Joey's brother and all of the other members of our family have experienced with his death. He was my husband's only biological child, and his brother's now left with no sibling. And as his mother, I truly feel as though a part of me is gone and just ripped away from me forever. Our lives were irrevocably changed that night that he died. Joey wasn't a troubled man, a young man. I want you to know that. He was a senior at ASU, just 5 months away from graduating. He was a gifted athlete and a good student, even making the dean's list at ASU the fall of 2008. He worked every summer. He made money. He spent it wisely. He had a loving and caring relationship with all of his family members. He had tons of friends all over the country, and over 200 of them appeared at his funeral to support us and to honor Joey. His life has affected them also dramatically. Unfortunately, tragedy struck once again 9 months to the day after my son's death, when one of his 2 college roommates shot and killed himself in front of his girlfriend after a heavy night of drinking and prescription drug abuse. This problem has just continued to manifest itself in that college environment. There have been 6 young men that have died over the course of the last year at that university alone. And in addition to that, as we've heard today, in Florida, we lose 7 people a day, and over 32,000 people a year die from adverse reactions to medication. So something simply has to be done with this epidemic. It's extremely important to me that I do whatever I can to make a difference. We've formed our National Coalition Against Prescription Drug Abuse, and I speak everywhere I possibly can to parents, students, educators, and community leaders about this problem. One thing that I wanted to point out that hasn't been mentioned today, I have a whole list of recommendations. Many of them have been talked about today. I think the one that I really want to make sure is mentioned is that the pharmaceutical industry has been allowed over time to expand its influence over virtually every facet of American life, using its near unlimited financial resources to influence the FDA and other governmental agencies, our educational research facilities, our legislators, unfortunately, and most alarmingly, our physicians and other medical providers. They're influencing medical research, drug trials, and are compensating doctors to prescribe medications they want to become their next blockbuster drug. The spider web of influence needs to be dismantled. Thank you very much for having me here today.
Thank you, Ms. Romero. Ms. Rivero. Mr. Harrison, you recognize for the 5 minutes, and please do try to keep an eye on that red light for me.
Yes, thank you, Chairwoman Bono Mack, Ranking Member Butterfield, and distinguished members of Commerce, Manufacturing and Trade Subcommittee for giving me this opportunity to speak before you today. I'm very honored to be here. My name is Dan Harrison. I'm a tribal member of the Muskogee Creek Nation of Oklahoma. I currently reside in Palm Springs, California, where I've been for the past 20 years. I have worked as a structural iron worker and achieved apprenticeship status. In September of 1995, I took a fall on the construction site. My fall not only resulted in a severe back injury, but led to a life of addiction. After injuring my back, I went on to disability for a couple of months, then finally went to an orthopedic surgeon, and I was told that I would need to have a surgery which could result in never achieving 100% mobility. I chose not to have the surgery and developed my own solution of physical therapy and pain medication. After 90 days, I stopped going to physical therapy and started drinking to intensify the effects of the pain medication. As the days went on, my drinking and opiate use increased, and my life started spiraling out of control. During this time, my wife and I separated, and I shared custody of our 2 daughters. In 1999, I remarried, and soon after, my 3rd child was born. This all occurred while I had severe dependence on opiates and alcohol. The drugs are what got me through the day. I never had to go back to the doctor's office after my initial injury so often. I developed such a strong relationship with the doctors that I had need only to call, and they would refill my prescription with no questions asked. I would go into local emergency rooms where the doctor would see me and wave me back for regular pain injections. I rarely had to resort to the streets for my medications. Depending on what type of narcotic I wanted and the method of administrating it, the drug resulted in which doctor I would call. In October of 2008, I decided I wanted to fight for full custody of my daughters. I felt that their mother was not caring for them the way that I felt they should be cared for. I decided to call Child Protective Services. After the investigation, they were removed from the mother's care. When the caseworker showed up unannounced at my home, I had several cabinets full of prescription medication. When I was confronted, I admitted to the recent use of Oxycontin, Vicodin, morphine, Lortab, Demerol, Dilaudid, and marijuana. After hearing myself admitted to the amount of drugs in my system and seeing the caseworker's response, I knew it was time to make a change. The only way I would ever get custody of my daughters was to get help. I entered the Family Preservation Court, otherwise known as Family Dependency Treatment Court. The Family Preservation Court applies the drug court model to child welfare cases that involve an allegation of child abuse or neglect related to substance abuse. The Family Preservation Court seeks to do what is in the best interest of the family by providing a safe and secure environment for the child while intensively intervening in the treatment of the parents' substance abuse and other comorbidity issues. This approach also results in better collaboration between agencies and better compliance with treatment and other family court orders necessary to improve child protective case outcomes. Since graduating from the program, I have learned that there are 2,500 drug courts, including over 300 family dependency treatment courts in the United States. I'm humbled to know that now over 120,000 addicted people a year have the opportunity for treatment and restoration in these courts, and I hope that someday they are available to everyone who needs them. These courts have been proven to cut up to 45% of the crime rate, and produce up to $27 for every dollar invested. When I first entered the Family Preservation Court, I had not accepted my problem, and I was a little uneasy with myself for calling the CPS since the investigation turned on me. However, after my intake and sharing my history with the Family Preservation Counselor, I realized how bad things had gotten. Through the Family Preservation Court, upon the counseling, I obtained guidance in educating my daughters about the addiction. I participated in parenting courses that taught me to effectively communicate with my children, how to create healthy boundaries. I was given support by my counselors and peers throughout my struggles with the reunification process. In 2010, I graduated from the Family Preservation Court. Today, I'm thankful that I called the CPS. Without their intervention, I would not be here today. Family Preservation Court has helped me realize that I needed help. I needed to get help for myself as well as my family. As a result of completing the program and completing other family parenting courses, I've vowed to work diligently with the program and CPS side by side to work to do some outreach work for the ones that are still suffering from prescription drug use in the local community as well as the tribal community in Southern California. I thank you for allowing me to come here and share just a little bit of my story. I realize today that I am a miracle that's set here because of my addiction and going through the process of my recovery. I realize how serious this epidemic is today. So thank you for inviting me here today to share my story. I'm very humbled by that. Thank you very much.
Thank you, Mr. Harrison. Dr. Boyd, you're recognized.
Thank you. Thank you for inviting me today. My comments draw on my research that's primarily funded by the NIH, among other sources. I've been studying this for the past 10 years. You've heard today that over the past 15 years, prescriptions for controlled medications have nearly doubled for adolescents and young adults. And these come from office visits, from ED visits, and significantly in this age group, from oral surgeons. And once the youth have the pills in their hand, they are at risk for diverting them. Approximately 10% of adolescents in a given year have diverted their pain medicines. 15% have diverted their stimulant medications. And like other researchers, we find that girls are more likely to divert by loaning and giving, and boys are more likely to divert by selling. There are also socioeconomic differences among these adolescents. Approximately 10% of all youth will divert their pills to their parents. Overall, 1 in 6 of adolescents with legal prescriptions will be approached in a given year to divert their medicines, and in some cases, they will be asked to rent them. It is usually stimulants in this age group that are being diverted, but not exclusively. We have found that the more elite the school and the more elite the university, the more likely diversion is to occur, and again, it is often stimulants. This is not to say that opioids are not the problem either, though. Motives to divert, as well as to use diverted medications, are wide-ranging, and it should not be assumed that the motives always involve getting high. Indeed, motives are one of the reasons that this problem is so difficult to prevent. So I'd like to share with you 3 cases from our own studies, and they highlight what we found in our research. The first one is a 16-year-old teen. She's an honor student. She was going to homecoming. She had a new boyfriend. 4 hours before the event, she got a migraine headache. And she went to her mother, and her mother gave her one of her own hydrocodone tablets that she had left over from her hysterectomy. The teen took it, went to the event. When I interviewed her, she had a great time, and she did not use hydrocodone again. The second case, a 15-year-old boy attends an elite high school and is having trouble getting his work done. His best friend has a prescription for Adderall and keeps it on the dresser in the house. And when his friend leaves the house, his friend takes the Adderall. When I talked to this young man, he said, well, you know, everyone in my school is using it. Everyone uses it to study. And then in the third case, this is a high school girl. She did have a history of alcohol abuse, who was given an oxycodone tablet from her girlfriend, who had also gotten it for oral surgery. She wanted to experiment to see what it does. Now, this is a girl that also was abusing alcohol. She crushed and snorted the pill, and she found herself continuing to use what she called oxy when she wanted to party with her friend. Now, these cases represent what we have found in our research. First, diversion in this age group usually occurs among family and friends. 2, there are gender differences. 3, it usually involves one primary prescription, and it is often from oral surgeons and dentists. 4, the diverted medicine is often started for the purpose of self-treatment, so that you see youth thinking that they're going to use it for a headache or that they're going to study harder. But then once they start using it, they have it available to them. And finally, the controlled medications are readily available. They are advertised on television. We do advertise controlled medications on television with direct-to-consumer marketing. And they are not stored properly, nor are they disposed of. And I hear this time and time again from youth. The adolescent girl that was in my case 3 is the one that is at the absolute highest risk. She is a polydrug user, and she's using for recreational purposes. It is these sensation-seeking youth that our data find have the biggest problems and are at the greatest risk for drug addiction and death. Most social scientists end their talk by saying we need more data, and I'm going to tell you that as well. It is difficult to understand why a country such as ours has data from 2006. We need regional data, we need national data that is more nuanced, that tells us the complexity of the problem. But policymakers can also do something. The FDA has recently stipulated that medicine bottles need to carry the schedule on them. I called my son, who has a prescription for Adderall, before I came here today, and I said, "Did you pick up your prescription bottle?" And he said, "Yeah." And I said, "Well, what about the labeling? Did it look different?" No, he said, "It doesn't look any different." I said, "Come on, Joseph, look, see if it looks different." Oh, yeah, maybe. This isn't enough. These bottles, I have a prescription that tells me on the back not to use it with grapefruit juice. These prescription bottles need to be clearly labeled that it is unlawful to share the medication, that that they need to be stored correctly, and how they need to be disposed of. The solution to this problem lies in the recognition that it is far more complex than actually street drug use, and it's going to require cooperation with pharmaceutical companies, healthcare providers, families, young people, and policymakers. Thank you.
Thank you. Dr. Arya?
Chairman Bono-Mack, Ranking Member Butterfield, members of the subcommittee, thank you for this opportunity to testify on the problem as it manifests among our nation's youth. I come at this issue as a researcher at the University of Maryland and the Treatment Research Institute in Philadelphia, but I'm a mom too. Since 2003, with my dedicated staff, I have led the College Life Study, a NIDA-funded study of more than 1,200 college students. Consider our findings regarding non-medical use. By the 4th year of college, 13% used a tranquilizer, 23% an analgesic, and 30% a stimulant without a prescription. We found that more than 1/3 with prescriptions shared or sold their medications, usually to a friend. Most commonly diverted are stimulants, such as Adderall, with a 62% diversion rate. And individuals who divert prescription drugs are typically non-medical users themselves. Let me sharpen the focus on this particular aspect of the problem, stimulants. They are widely available and attractive to students with high task demands, especially those experiencing academic difficulties. There is a popular assumption that taking stimulants non-medically confers an academic edge and is therefore beneficial. Headlines referencing smart drugs perpetuate the notion that non-medical prescription stimulant use increases academic performance. Scientific evidence tells us quite the opposite. It is not the academically successful students who use them, but the unsuccessful ones. We know that non-medical users compared to non-users are more likely to be dependent on alcohol and/or marijuana, skip class more frequently, and spend less time studying. And digging even deeper, we see that these academic problems are related to heavy drinking and marijuana use. What the research shows is that non-medical prescription stimulant use is an unsuccessful shortcut, an attempt to compensate for declining academic performance, and is a red flag for an underlying alcohol or drug problem. What can policymakers do about prescription drug abuse? The single best thing is to tighten the chain of custody that ultimately governs supply. For example, put in place better prescription monitoring programs, reform physician dosing practices, and create timely surveillance databases. National data are often old, and state-level data are not even available to researchers. The prescription drug problem has complicated the landscape of existing drug threats. It does not occur in isolation. Individuals who use prescription drugs non-medically are very likely to be heavy drinkers and/or illicit drug users. Therefore, in addition to dealing with this devastating symptom, we must redouble our efforts to develop innovative solutions to the root issue. That is the larger public health problem of drug use and addiction in the United States. What specific strategies should be proposed? Today, I recommend two things regarding prevention and intervention. One, modernize the nation's infrastructure for early detection. We can identify those who are at highest risk for drug problems, just like knowing who's at risk for other chronic health conditions. With an approach that involves standardized assessments, early intervention, and promotes teamwork between parents, physicians, and educators, we can put these young people back on track to fulfill their potential. To this end, NIH research has yielded valuable information about risk and resiliency, the interplay between genetics and the environment, and the natural history and course of addiction. Effective solutions to this enormous public health threat will require continued funding for NIH research. Number two, connect the dots between drug use and academic problems. This link cannot be ignored any longer. Making this connection loud and clear will get the attention of parents who want who want more than anything else to see their child succeed. Tacit approval by parents and students of underage drinking as normative and college as a 5-year party, especially when there are stimulant drugs as a last resort, is completely misguided but regrettably an all too common notion. Similarly, we must engage the leaders of our education system who are concerned about the high school dropout crisis and less than optimal college graduation rates. They must recognize the very real and contributory role of drug use to poor academic achievement. Sustaining our economy and navigating future challenges will require a clear mind and a sharp focus, which is inconsistent with underage drinking, excessive drinking, illicit and non-medical prescription drug use. Again, thank you for shedding light on this continuing public health problem and allowing me to contribute to the discussion on solutions.
Thank you. I thank all of the panelists very much. Certainly the parents who are hurting. I thank you for your advocacy and your passion turned towards helping others. Dr. Boyd, the statistics I'm looking at completely dispute what you're saying. As I look at the Drug Abuse Warning Network statistics as published by SAMHSA, you said that stimulants are the problem, and you also say that opiate addiction has doubled. Did I not hear that correctly?
No, that that prescriptions for controlled medications for young adults and adolescents, I think this is what you're referring to, has nearly doubled since 1994 to 2007. This is Fortuna's work, what's published in Pediatrics.
Now, this is not specific to adolescents, but when I look at these numbers for the increase of emergency department visits, now old data, but from 2004 to 2009, stimulants altogether, again, not specific to adolescents, but I would think the trend would be similar. 20,490 admitted to ERs in the year 2004. That increased to 25,889 by 2009, 5,000 person increase over those years. While oxycodone and combinations and thereof, 41,701 in 2004. One would think to act that the crisis is similar, that would double, but in fact it actually increased to 148,449. So you spent the bulk of your time talking about stimulants, but I'm not aware particularly, I'm sorry I don't have the data here, but would you say that the trend line for stimulants and fatalities for stimulants is similar to opiates and OxyContin?
No, I wouldn't. And actually, I did not intend to give the impression that I was mostly talking about stimulants, actually. When I was speaking of the controlled medications, I was speaking of the 4 schedules, and that, for instance, 10% of my, in our sample, had diverted their pain medication, where 15% had diverted stimulants. Remember, this is 12 to 7.
Let me jump to Ms. Creedon here, because, and even to Mr. Harrison, and thank God that you are here as a recovering addict. I'm so proud of your courage. Thank you for being here. And to Kathy Creedon, I mean, this is the scientific community, and you guys have lived it in the real world. Is this just diversion from the simple places they see? Kathy, Ms. Creedon, in your testimony, I wish you would go on a little bit more. You talk a great deal, and you didn't talk, you mentioned you have 7 pages of documentation that show the runaround and what they call the smurfing of the great lengths your son went to that had nothing to do with your medicine cabinet. Would you be willing to submit your 7 pages and 72 entries of medical history? Would you be able to submit those things for the record, congressional record, so we can take a look at all of that? But are you hearing what you witnessed on the real street side of what's really happening out there in California and the homes? Is it paralleling what the scientists are saying here?
That the drugs are coming from parents' medicine cabinets? Is that
Or
the question?
Perhaps I'm a little on edge. It almost seems that you act as if a 16-year-old honor student was given a hydrocodone, Dr. Boyd, and the teen went to the event. She had a great time, but she never used hydrocodone again. So it seems to downplay, and you're acting as if, the diversion is, well, mom gave it to a 16-year-old. She had a great time at a party. And I just take issue with that, because this is a mother who never, ever dreamt of doing such a thing.
Absolutely. But speaking as a social scientist, this is also happening, so that when we look at the data on diversion, we see all kinds of diversion. And we see that also parents are role modeling sharing medications that are controlled. The mother shouldn't have had extra hydrocodone available.
But Ms. Creedon, you had no hydrocodone, you had no oxycodone. Can you speak a little bit about the great lengths your son went to that had nothing to do with this? You are like Ms. Rivero and Mr. Bauer, a loving parent doing your best to raise a teenager, young Ms. Creedon.
Yeah, if I can speak to this. I mean, I think the reputation certainly is out there and we've heard a lot of that today, that I guess there were some statistics floating around that most people get these drugs from their parents' medicine cabinets, but in our case, that did not happen. We never had any of these drugs in our house. My mother never condoned using drugs. I mean, when we do submit these records, I mean, Ryan went out of his way to visit every doctor imaginable and finagle every aspect of the system to make this work. And surprisingly, it wasn't that difficult. And so it's kind of hard for us to sit here and hear people talk about, I guess, parent responsibility, when really I think the bigger issue is responsibility, or rather irresponsibility, of the medical community, and that none of these drugs came from our home. All of these drugs that Ryan used and the drugs he died from were obtained legally from licensed physicians.
Thank you. I have to yield now to the ranking member, Mr. Butterfield, but we will have a second and third round of questioning. So, Mr. Butterfield, recognized.
Let me thank the chairman for convening this very important hearing today. Those of us on this side of the aisle are also acutely aware of the pervasive problem that we have with prescription drug abuse, and so the hearing today is very timely, and I want to thank the witnesses for their testimony. In my prior life, I was a trial judge in North Carolina. I did that for 15 years, and so I have seen and heard heart-wrenching stories for many years over my career, and I want to extend my personal condolences and concern to those families who have been directly affected. I want to just ask 1 or 2 questions. I won't belabor this unnecessarily, but let me start this way. Prescription drug abusers do so for a variety of reasons, and I think we recognize that today. There are many reasons that contribute to this problem. Some people use them recreationally, some seeking their euphoric, relaxing, or energizing effects. Other people with or without a prescription use them inappropriately, seeking to alleviate minor pain and treat a perceived illness or even to manage stress. Still other people use prescription drugs for their intended purpose, but obtain them without a prescription. To Dr. Rear and Dr. Boyd, do we have data in percentage terms which demonstrate either for the population as a whole or for high school or college-age individuals why prescription drugs are being used? In other words, for what reasons by percentage do young people decide to take prescription drugs without a prescription?
Sure.
Yes.
The percentages vary by class of prescription drug. So for stimulants, I would say about 3/4 of people who use stimulants take them to increase concentration to study, and the scenario sort of plays itself out that I explained, where they're having academic difficulties. Only a small percentage of them will crush stimulants to get high. On the analgesic side, many, many more, a higher percentage, probably about 80%, will use them to get high. And a very small minority will use them because of curiosity reasons or for other reasons. And for the tranquilizers, we see a lot of self-medication going on, where there might be an underlying mental health issue. So it varies by class. And that's for the college-age population, young adult populations. We do not have that level of data at the national level. The National Household Survey, the National Survey on Drug Use and Health, does not collect that level of information for us.
And I studied 12 to 17-year-olds, so it's a younger group, and they are less likely to use any drugs, the 12-year-olds and 13-year-olds. So you see some differences. We also see differences by drug class, and they mimic much of what Dr. Arias said, with the exception being the opioids, where disproportionately the younger the child with the opioid, the more likely they say they're treating pain. Once they get older, so that now they're into 11th and 12th grade, now when they're using diverted opioid medications, they're using it to experiment, to get high, to help them sleep, but that may be because they're using stimulants or they're drinking or partying. But so it would be for sensation-seeking or recreational reasons.
Can we quantify what percentage of users are snort as opposed to crushing the medication? What percentage are snorting it? Do we know?
Of 12 to 17-year-olds?
Well, your age group, yes.
Relatively few are snorting it. And it depends by grade. 12-year-olds and 13-year-olds are not snorting it. We see about 5 to 10% snorting it by the time they get into high school.
What about combining it with alcohol?
They all combine it with alcohol.
That's a common
They absolutely,
Yes.
Our data show that any youth that is using the opioid products to get high or to sensation seek or for recreational purposes are using other drugs as well. And they're also using other prescription medications.
Would that be the same in the older age groups as well, Dr. Rira? Yeah.
What we find is that there is always a history of excessive drinking or a history of marijuana involvement. And in some cases, they're using it at the same time, concurrently, during the same session. But for instance, in our data, 88% of the non-medical prescription drug users had a history of marijuana use in the past year.
So there are similarities between the 12 to 17 and the 18 and above.
There are, particularly when you get to 16, 17, and 18-year-olds. The younger ones, which I'm also studying, who are in middle school, they do look different.
Well, let me thank you and thank all of you for your testimony. I yield back.
Thank you, and I do ask unanimous consent that the information that I requested from Ms. Creighton be allowed to be included in the record. No objection? Okay, so ordered. Dr. Aria, you keep mentioning the history of use, and that they use. Do you believe? It's my belief as a mother who just got through high school that the powerful nature of these painkillers, that our kids do not have a chance. Can you speak to the adolescent brain, specifically what does happen when they get that tablet of OxyContin? Can you speak also to a farm party and explain what that is?
Sure. I think it's very true that the addictive potential of opioid analgesics trump what we're talking about when we see marijuana, other drugs. So what really appears to be the issue is that because it's more typical for alcohol, marijuana to be used at younger ages, there are some people who are more predisposed to using substances. We know that. And the adolescent brain is more set up to take risks naturally. And so that combination of being an adolescent and having a propensity for addiction sets up a course where you get involved with alcohol, marijuana, and then it exposes you to drug-using peers. Like I said, you begin to lose interest in other things. You get involved in prescription drugs. And then you hit a very, very highly addictive substance. And that's what you're talking about when they don't stand a chance. So if they have a propensity for addiction, plus they're in the stage of adolescence.
I have no PhD, but I beg to differ that if they have a predisposition to addiction, because I believe that every human brain has the potential to be
100% of people have some propensity for addiction.
I'm sorry, can you repeat that? Because
100% of people are at risk for addiction if they are exposed to addictive substances.
And then an adolescent then?
An adolescent would be even more so because of their risk-taking behaviors.
But risk-taking, a white pill to them is a lot less risky than meth or than...
Well, what we find is that in terms of, we've done studies on perceived risk, and the risk of medications falls in between marijuana and cocaine. So they don't see it as less risky than marijuana. They see taking prescription drugs medically or non-medically is more risky than marijuana, but less risky than cocaine. So that's where it falls.
Briefly, let me just lead you to the answer that I want to hear. On another question, farm parties. It is my understanding, is it not true that kids now go to parties, throw bunches of pills into a bowl and grab whatever they can and swallow it to be risky?
We have heard of that. We have heard of that happening. We're not sure how often it happens. What we do know is that the variety of drugs used is much more, there's much more variety of different drugs used on the same occasion than there were years ago.
Okay.
That's what we know now.
Thank you. Mr. Harrison, how helpful now is the medical community? If you walk into a pharmacy, do you have the ability to tell your pharmacist, I'm a recovering addict, please don't prescribe, my drug of choice to me, or help me if I do? Do you have that ability? Are they helpful to you now?
I went through a process of a second back surgery with a 12-month sobriety, and it was difficult for me to have them administer more intravenous drugs to me because I was going through recovery. But I haven't yet attempted to gain any access since my recovery, so I haven't attempted, to talk to any doctors that I've dealt with in the past. Them knowing the severity of my injury in the past, like I said, I had built that relationship with them, and I see them from time to time in the community, and so the access was real easy. But since my recovery, I have 30 months in recovery, and I haven't yet attempted to go back.
Terrific. Well, congratulations on your 30 months.
Yeah,
Mr. Bauer, how are you finding a good avenue for your advocacy and making a difference out there? Good answer. Nice, short, and sweet. Okay, I'll yield to Mr. Butterfield for the next 5 minutes.
Thank you very much, Madam Chairman. During one of the earlier panels, and I apologize for not being here, I forewarned the chairman that I had another commitment this morning that I could not resolve. But during one of the panels this morning, a lot of time was devoted to discussing monitoring programs. I believe databases are an important tool that should be in our toolbox, but we need to treat the non-medical use of prescription drugs with many different tools, with multiple tools, and treat it as a public health issue, not just a law enforcement issue. For example, we need better education of patients and parents and friends and doctors and dentists and every person in society. Dr. Boyd, in your testimony, you mentioned better labeling as one of those tools. Can you describe what you would envision to be on a label, and would this be on all prescription drugs or just those that are the most risky if diverted?
Well, I'm also a nurse, and I would like to see better labeling on all medications, but let me direct my attention to the control medications that are more likely to be diverted and abused. I would recommend that we label them that it is unlawful to distribute them. Many of the kids that I interview do not know, and parents do not know, that mother of the homecoming who was going to homecoming, she didn't know she was doing something illegal. They should know it. It should be labeled on the bottle. There should also be directions on how to dispose of extra medicine that is left in the bottle so it's not sitting in the medicine cabinet. And finally, not only should they know where to dispose it and that it's unlawful to distribute it, but they should also know that it has addictive potential and abuse potential. We label, many medications I've gotten have been labeled more fully than the medications that are controlled.
All right, let me come to the other end of the table, Ms. Creedon. Aside from labeling, and I'd like Dr. Boyd's assessment of this, but aside from labeling, what can we do to increase public awareness of prescription drug abuse? We've got to become more proactive so other families do not have the tragedy that you've experienced. What can we do? Yeah.
You know, that's a really good question. I don't know the answer yet, but I intend to hopefully be able to make a difference by this organization that I've started, and our goal is to reach out, first of all, to students in high schools, middle schools, college age, the parents, and I really would like to reach out to the medical community as well, because that was a specific problem in my son's, that led up to his death. In these 7 pages, I document, if I could just take a minute in the beginning, where my daughter and I had a face-to-face meeting with the director of the medical facility, where we said to him, Ryan has an addiction problem. And like I said, because of privacy laws, we were not able to speak about certain things, you know, because of breaking laws. But he did tell me that he would go and speak to the physician that Ryan had an appointment with 2 days later. That conversation apparently never took place, and I just feel that if he would have taken our conversation seriously, coming from a family member of Ryan's history of drug abuse, that could have stopped the other 6 pages of his hospitalizations and everything else that went on. So for me particularly, I feel that the medical community doesn't take addiction seriously because maybe they are just not aware, you know, of what a few pills can do to somebody. In my son's case, it led to his death.
What about public service announcements on TV channels that are watched by young people?
That's one of the things that we hope to be able to do.
Yeah, MTV and BET and some of the other channels.
Absolutely.
Yes.
There are some things already being done directly to young people on the websites and things that they listen to about the dangers of, you know, prescription drug abuse. So yes, that would be
We need to do it, and we need to do it repetitively.
Exactly.
One thing we've learned in Congress, if you say something over and over and over again, people will listen and sometimes believe it.
That's what I read in all the
Yes.
educator material that I've been researching lately, is that it does have to be repetitive, and so it would almost mean being present on a high school property, like on a weekly basis, just over, you know, just over and over telling them the dangers of the drugs before they go to a party on Friday night.
Thank you. Thank you again. I yield back.
All right, thank you. We'll do 5 more minutes, and then we'll conclude the panel and move on to the next. Unless you'd like another 5? which I'm certainly fine with. I just don't want to make you do it. If I was so busy listening to what you were saying.
We're going to have votes in about,
Okay.
about an hour, yes. Yeah.
Dr. Boyd, back to you. Labeling. My understanding through the years of my research on OxyContin that actually the label was what turned kids on to the ability for the misuse. I think that labeling is not nearly, it's not going to be the answer. I don't know how old your son is, but I believe that it goes back to me to the DEA and the FDA and the supply chain and figuring out how the stuff is getting out there and why we're buying back hundreds of tons of this, hundreds of pounds of this stuff, hundreds of whatever the astronomical number is. So it's got to be beyond labeling. Let me just jump to Ms. Creedon again. Again, your testimony is terrific, but you spoke to the medical community and frustrations with them. But since Ryan's death, you've worked with the medical community and the doctors overseeing the HMO. And it's my understanding that they did learn a lot from you and that they've agreed to change their prescribing practice for such powerful painkillers. Is that true? And have you followed up on that? That you are able to actually educate in your community, your HMO, and get a change?
Yes, that is true, and I was very happy that they were receptive to hearing the information. I printed out a lot of information from the internet and shared it with them, and in fact the medical director told me that he took the information that I gave him and presented it in front of a staff meeting that they had, and they, in fact, after my meeting, made a policy within their organization that covers approximately 3,000 physicians and over 300,000 members, that those physicians could no longer prescribe OxyContin for the patients unless they had fourth-stage cancer and they had tried everything else. So I feel that was a huge victory, that the education that I gave them made that change. And I haven't been able to follow up with the outcome. I intend to do that, but I don't know right now if that's still happening.
I congratulate you on that, and it goes to Ms. Rivero. In your testimony, you say the same thing. Actually, you advocate. You say that your son had never been treated for any of the conditions listed on the doctor's record as a basis for her prescription for the powerful painkillers. Were you surprised by how easy it was for him to get access to those medications?
Not only surprised, I was shocked. I had never heard the term pill mill. I had not heard about dirty doctors. This last year has been a complete education, a complete upskill education for me. Shocked, absolutely shocked. And I've learned that that is the case throughout the country. I talk now to parents all over the place, California to Florida, and it's happening. There are so many unscrupulous doctors out there that are giving it out. They're in a pill mill kind of environment, but it's not just those doctors. It's also those that are really well-meaning, but they are not really, I don't think, well educated about pain management treatment. I've been told, I don't know if it's true for sure, but I've been told that doctors get less pain management training than veterinarians do. And that's horrifying to think about, but if it's true, my gosh.
Would you agree with that statement, Dr. Boyd, Dr. Arya? Do you know about the level of training that physicians do get before they can prescribe these things?
I know it's gotten better, but I know that I can speak to the addiction medicine side. They really are not given proper training at the graduate level, graduate medical education on addictive disease.
Dr. Boyd?
And I agree with that. It's just inadequate.
Thank you. And I will just use my last minute. I think we agree with Ms. Creedon, Ms. Rivero, on trying to limit the scope on when it is prescribed. I think that's hopefully something we can push for in Washington. But I really just want to thank you all very much for your commitment and your advocacy to this. And I don't know where it's going to go. I'm frustrated last night in my research to see that there was a Senate hearing in 2002 that's very much like the one we're holding today. I think that's frustrating, and I think we're failing. And it's a tough time for budget cuts, and we all have questions on how we spend our money. But we can do a better job, and I think the American people want an effective government, and in this case, it's not being effective. So I look forward to working with each and every one of you, and if you had another 5, I'm willing to yield to the gentleman. If not, we will let's take a quick recess and see the next panel. Thank you all very much.
Dude, I'm getting out of here. I can't fit it.
The first will be, thank you, whoever did that. First up will be Sean Clarkin, Executive Vice President of the Partnership for a Drug-Free America. Also joining us is General Arthur Dean, Chairman and CEO of the Community Anti-Drug Coalitions of America. Then we'll have Dr. Koster, Senior Vice President of the Generic Pharmaceutical Association. Our fourth panelist is Kendra Martello, Assistant General Counsel, Pharmaceutical Research and Manufacturers of America. Also testifying, Michael Mayer, President Frank Mayer and Associates. And our sixth witness is Patrick Coyne, registered nurse, testifying on behalf of the Oncology Nursing Society. Welcome, everyone. Thank you very much for being here today. I think you know the drill, 5 minutes, green, yellow, red. In America, we generally know what that means. So just please make sure you press the microphone to turn it on. And Mr. Clarkin, you are recognized for 5 minutes.
Chairman Bono Mack, Ranking Member Butterfield, members of the subcommittee, thank you for inviting me to testify about the problem of prescription drug abuse and the diversion of prescription medicine. The abuse of prescription medications, legal substances of tremendous benefit if used appropriately, is the single most troubling phenomenon on today's drug landscape. According to the 2010 Partnership Attitude Tracking Study, PAT study, 1 in 4, 25% of teens report taking a prescription drug not prescribed for them by a doctor at least once in their lives, and more than 1 in 5 teens, 23%, has used a prescription pain reliever not prescribed for them by a doctor. Why have we as a nation not been able to reduce this highly risky behavior? There are several reasons, many of which we've already heard today. The first is ready access. These substances are readily available to teens in their own medicine cabinets and the medicine cabinets of friends and family, and very often they're available for free. Nearly half, 47% of teens in our PAT survey say that it's easy to get these drugs from parents' medicine cabinets, and more than a third say it's available everywhere. Another reason is low perception of risk. The low perception of risk that's associated with abusing prescription drugs. Partnership research shows that less than half of teens see great risk in trying prescription pain relievers such as Vicodin or OxyContin that a doctor did not prescribe for them. Low perception of risk coupled with easy availability is a recipe for an ongoing problem. Third reason that we've heard a lot about, especially from Dr. Boyd, is the motivation to abuse. We have traditionally thought of teens abusing illegal drugs and alcohol either to party or to self-medicate for some serious problem or disorder, adolescent depression, for example. But our research, like Dr. Boyd's, shows that teens appear to be abusing these drugs in a utilitarian way, using stimulants to help them cram for a test or to lose weight, pain relievers to escape some of the pressure they feel to perform academically, tranquilizers to wind down at the end of a stressful day. Once these substances have become integrated into teens' lives and abused as study or relaxation aids, it may become increasingly difficult to persuade teens that these drugs are unnecessary or unsafe when taken without a prescription. The fourth reason, and this is a particular focus of the partnerships, is the lack of parental activism in prevention of this behavior. Parents, who are usually our most valuable ally in preventing teen drug use, find it hard to understand the scale and the purposefulness with which many of today's teens are abusing medications, and it's not immediately clear to these parents that the prime source of supply for abusable prescription drugs may well be their own medicine cabinet. Many parents themselves, moreover, are misusing or perhaps abusing prescription drugs without a prescription. In research that we did in 2007, 28% of parents said that they themselves had used a prescription drug without having a prescription for it, and 8% of those parents said that they had given their teenage child a prescription drug that was not prescribed for them. Finally, the reason we've not been able to reduce teen abuse of prescription medications is that our efforts as a nation have been inadequate, at least to date. There simply has not been sufficient public attention or resources dedicated to this threat. The backdrop to all of this is that the national drug prevention infrastructure has been eroding for the past few years as the budget for the National Youth Anti-Drug Media Campaign has shrunk significantly, the Safe and Drug-Free Schools and Communities State Grant Program has been eliminated, and changes have been proposed to the State Prevention and Treatment Block Grant that could put prevention funding in jeopardy. With dwindling resources, it's impossible for government to be able to mount the kind of effort that's necessary. We know that when there is a well-funded effort to educate parents about the dangers of prescription drug abuse, we can increase awareness and we can make a difference. In the first half of 2008, the Office of National Drug Control's Policy's National Youth Anti-Drug Media Campaign devoted $14 million, with the media match was a $28 million effort, to a parent-targeted campaign aimed at raising awareness about the risks of medicine abuse and motivating parents to take action. The campaign, actually, in terms of parents' perceptions of the problem and intent to take action, was demonstrably successful. This shows that a major public education campaign can help to turn the tide on this entrenched behavior. The media campaign's funding is in jeopardy and may even be eliminated in the coming years, so we can't assume that that campaign will be around to deliver this message. The private sector will need to help finance a campaign of the magnitude necessary to change the attitudes that underlie this behavior. While the partnership is grateful for the unrestricted support we have received from a number of pharmaceutical companies, if our nation is going to reduce teen abuse of prescription medication, we need to step up efforts dramatically. We need a sustained multi-year effort funded by the pharmaceutical industry, the generic drug manufacturers, and other key stakeholders to, first, support a major independent paid media campaign alerting consumers to the risks of abusing medicine and the importance of safeguarding and safely disposing of medicine. This effort might include tagging the pharmaceutical industry's large inventory of direct-to-consumer advertising and pointing viewers towards an objective and comprehensive online prevention resource. Second, we need to educate and enlist prescribers, pharmacists, and other healthcare professionals. Third, we need to educate policymakers so that we can promote policies that will help reduce both the supply of and the demand for prescription drugs of abuse. And finally, implement an evaluation tool that would measure and hold this program accountable. In conclusion, at the partnership, we believe that the abuse of prescription medications, legal substances of great benefit when used properly, is the single most troubling phenomenon on today's drug abuse landscape. We appreciate the time and the attention that the subcommittee is giving to raising awareness and looking for ways to reduce the abuse of prescription drugs in our country. The partnership at drugfree.org stands ready to work with the subcommittee on this and other substance abuse matters. Thank you very much.
Thank you, Mr. Clark. And General Dean, you're recognized for your 5 minutes.
Chairman Bono Mack, Ranking Member Butterfield, and other distinguished members of the subcommittee, thank you for the opportunity to testify today on behalf of Community Anti-Drug Coalitions of America, CATCA, and our more than 5,000 community coalitions nationwide. I am pleased to provide you with CATCA's perspective on the complex problem of prescription drug abuse. CATCA has been on the front lines addressing prescription drug abuse for nearly 10 years. We have hosted town hall meetings, developed publications and toolkits for coalitions, and produced television programs on this subject. In 2009, we were fortunate enough to conduct a rally with over 1,000 community leaders on Capitol Hill to raise the awareness of over-the-counter as well as RX abuse. CATCA recognizes that the misuse and abuse of prescription drugs is a multi-dimensional problem that demands comprehensive, coordinated solutions at all levels, local, state, and national. Population-level changes in substance use, including prescription drug abuse, can be achieved by a comprehensive, data-driven approach. This approach mobilizes key community sectors. They work together to educate, reduce access and availability, and change perceptions as well as social norms. Where this infrastructure is in place, communities have successfully prevented and pushed back against a variety of drug problems, such as marijuana, methamphetamines, K2, and the misuse and abuse of prescription drugs. The Drug-Free Community DFC program is the best example of a comprehensive community-wide approach being taken to scale nationwide. Since 1998, the DFC program has been a central bipartisan component of our nation's demand drug reduction strategy. A recent evaluation of the program found that youth drug, alcohol, and tobacco use are significantly lower in DFC-funded communities than in communities without a DFC coalition. CATCA trains DFC grantees and other community anti-drug coalitions to execute 7 evidence-based strategies to affect community change for drug use. Coalitions across the country are implementing these strategies, and these strategies range from raising awareness to changing policies, and they are achieving measurable results and reducing local prescription drug abuse rates. In the interest of time, I would like to share just one example from Caribou, Maine. The Aristook Coalition used a multi-sector approach to identify prescription drug problems and to craft a strategic action plan to address them. The coalition did the following. 1, they implemented a comprehensive social marketing campaign. 2, they provided training to healthcare providers about proper prescribing. 3, promoted and funded a prescription drug take-back program. And 4, created a monthly mailer for healthcare providers that lists individuals charged with prescription drugs-related crimes in their communities. As a result of this data-driven multi-sector approach, the coalition achieved significant outcomes. Through the coalition's effort, the county has maintained lowest rate of past 30-day prescription drug use among high school students. Similar coalitions examples are highlighted in my testimony, and I would invite those to your attention. CATCA's primary message today is to this committee is that community coalitions are evidence-based and effective and should be utilized as a major component of any prescription drug prevention strategy. We recommend that the coalition model be implemented in concert with a number of other key approaches. For example, CATCA supports the expansion of an effective prescription drug monitoring programs to ensure adequate coverage in every state. The data from these programs can also help identify hotspots and appropriately direct the attention to other resources. We need enhanced education opportunities for training for medical and dental professions. We also need increased awareness and education about the danger, proper storage, and disposal of drugs. We support enhanced opportunities to make prescription take-back programs routinely available. We strongly support increased law enforcement to remedy such things as pill mills. Our nation needs to embrace and enhance all these strategies. We need to expand the number of DFC-funded communities. And finally, we need to increase training at the local level so that more communities can effectively address this major public health and safety threat. I thank you for the opportunity to testify before you today and applaud you for your great work. Thank you.
Thank you, General, and we're honored that you're here, and I thank you for your service and that you came in under the wire, because there's one person I couldn't gavel down, and it would be you, sir.
And thank you for your great support and on a continuing basis. We appreciate it very much.
Thank you. I look forward to our continued work together. Dr. Costa, you're recognized for 5 minutes.
Thank you. Good morning, Chairwoman Bono Mack, Ranking Member Butterfield, Congressman Lance, members of the subcommittee. I'm John Koster, Senior Vice President of Government Affairs at the Generic Pharmaceutical Association and a licensed pharmacist. On behalf of GPHA and our member companies, thank you for calling this hearing and for the opportunity to testify. Let me begin by giving some background on the role of the generic drug industry in the United States. About 75% of all prescriptions are filled with generic medications, although that percentage does vary by therapeutic class. We are proud that our industry helps make high-quality, safe, effective prescription medications more affordable for millions of Americans while saving the healthcare system billions of dollars each year. GPHA's member companies manufacture FDA-approved generic versions of brand-name drugs in all therapeutic categories, including prescription painkillers. We are as concerned as the members of this committee when medications that are made to improve lives or alleviate pain are abused. We believe that addressing this issue, as you've heard from the previous witnesses, will require continued coordination among federal and state agencies, state, local, and federal law enforcement, health professionals, drug manufacturers, pharmacists, patients, and their families. Because it is a multifaceted problem, it requires a multifaceted solution. As we work together to shape public policy to end the misuse of pain medications, we must recognize that the overwhelming majority of individuals, including millions of seniors and cancer patients, do rely on these important drugs for their proper pain treatment. We are absolutely committed to the safe and reliable manufacturing and delivery of generic drugs. As an industry, we have invested millions of dollars into technologies and delivery systems to help assure that our products reach their destinations safely and securely. For example, with respect to opioid pain medications, the DEA has a closed system of distribution to prevent diversion. Our industry works with the DEA to assure that these products do not fall into the hands of abusers. For example, the DEA administers drug allotment and accountability systems to assure against the loss of diversion of controlled substances. Recent studies suggest that the problem of prescription drug abuse stems not from drugs that have escaped the legitimate supply chain, but those or been obtained illegally through the black market, but instead from those that were legally prescribed and available in the home. Why are these medicines sitting in medicine cabinets? Shouldn't patients have already taken them? It is not uncommon to find many medicine cabinets in America are stocked with unused prescription drugs. Some of these may be for mild conditions such as allergy, while others may be unused medications that were prescribed to treat the discomfort of a surgery. Many Americans have no recourse to return these unused medications, especially controlled substances, because federal law prohibits the transfer of controlled substances from an ultimate user to anyone other than law enforcement. This will soon change as DEA implements the Safe and Secure Drug Disposal Act, which will permit ultimate users, such as patients with excess controlled substances in their medicine cabinets, to return them to DEA registrants, such as willing pharmacists, so they can be destroyed. What has our industry been doing to help address this problem? In general, we have tried to support efforts that are dedicated to raising awareness to the dangers of prescription drug abuse, as well as the need to properly dispose of unneeded or unwanted prescription medications. We think education is a key component to this. For example, we support efforts such as the American Medicine Chest Challenge, which is a community-based public health initiative with law enforcement partnership to raise awareness about the dangers of drug abuse. We are pleased to let you know that we will be partnering with pharma to produce a public service announcement that will promote the upcoming DEA Take Back Day on April 30th, which we hope will be as successful as the one from last fall. We are also a board member of NCPI, the National Council on Prescription Information and Education, a broad-based coalition addressed on raising awareness about prescription drug abuse. For example, NCPI most recently developed a college resource kit to help educate students about the dangers of prescription drug misuse. In addition, over the last few years, our industry companies have focused efforts in this area by joining with the brand name industry, patient groups, and the FDA on working on a REMS program for long-acting and extended-release opioid medications. REMS are special programs that are used by FDA to help prevent adverse outcomes in patients. At this point, I don't believe the FDA has implemented that program yet. Madam Chairwoman, we applaud you for the countless hours you have devoted to raising awareness about this issue and the great work you have done. With the cooperation of physicians, law enforcement, and others, we can expand education efforts, keep our supply chain safe and secure, and help ensure that patients and family members are not alone in this fight. We thank you for holding this hearing, and I would be happy to answer any questions you may have.
Thank you, Dr. Koster. Ms. Martello?
Good morning. Thank you, Madam Chair, and distinguished members of the subcommittee, Ranking Member Butterfield and Congressman Lance. My name is Kendra Martello, and I'm pleased to offer this testimony today on behalf of the Pharmaceutical Research and Manufacturers of America, or PhRMA. PhRMA's members represent America's leading pharmaceutical research and biotechnology companies. Last year, our members alone invested over $49 billion in discovering and developing new medicines. Industry-wide research and investment reached more than $67 billion last year, a record. The prescription medicines our members research and develop are life-saving and life-enhancing medicines that allow patients to live longer, healthier, and more productive lives when used appropriately and as intended. It's important, as we consider the non-medical use of prescription medicines, that we also balance the need to maintain patient access to these medicines for legitimate medical use. We believe addressing the public health problem of prescription drug abuse is a shared responsibility. It requires a comprehensive, consistent, and sustained approach and commitment from a wide range of stakeholders, including prescribers and pharmacists. No one manufacturer, brand or generic, recognizing that approximately 75% of the prescriptions dispensed are for generic medicines, no one trade association, and no one stakeholder group is solely responsible for implementing a solution that will truly be effective. We all must work together to achieve a common goal. And PhRMA and our member companies are committed to being part of the solution. An important part of our educational message surrounds the appropriate use of medicines, which can reduce health care costs overall. Data also show that the majority who misuse or abuse prescription medicines do obtain them from a friend or family member. We believe education can have a significant impact in helping to inform the public and reducing the overall rates of prescription drug abuse. We've developed 4 simple messages as part of our educational effort on this important issue. First, take your medication exactly as prescribed. Second, store all medicines in a safe manner out of the sight and reach of children and adolescents in particular. Third, don't share your medicines with anyone, including friends or relatives. And fourth, promptly dispose of any unused medicine in a safe manner, either through the household trash or an appropriate take-back program, such as one administered by the DEA. In fact, to help further this last message, Pharma partnered with the U.S. Fish and Wildlife Service and the American Pharmacists Association in 2007 to create the Smart Disposal Program, which educates consumers about how they may safely dispose of most medicines through the household trash. Pharma and our member companies have also undertaken significant educational efforts regarding prescription drug abuse. For example, we've recently worked with the Washington Health Foundation and the State Attorney General to develop education for college students, and with Dare America to help educate students in grades 5 through 12. We also believe specific educational efforts must be targeted towards prescribers and pharmacists and could help them to detect and refer for treatment those who may be abusing prescription drugs. Other ideas that could have a significant impact on reducing the rate of non-medical use of prescription drugs. First, increase the use of and improvements to state prescription drug monitoring programs, which can be an important tool in preventing and detecting abusers and referring them for treatment. Second, reauthorize NASPR, which provides grants for the state monitoring tool and which is legislation that Pharma has supported. Third, increase penalties for and enforcement against pill mills, medicine diverters, and those who go outside the legitimate medical supply chain, including rogue internet drug sellers. Fourth, work with FDA and others to facilitate the development of medicines to treat addiction and mechanisms to make medicines less susceptible to abuse. And finally, work with the DEA as it develops regulations to allow ultimate users and long-term care facilities to return controlled substances for disposal. In conclusion, prescription medicines, when used as prescribed, are critical to improving and extending patient health. However, when they are misused or abused, they can be dangerous and even deadly. No one solution to this public health problem exists. Education is of critical importance, and it's a key first step, but we must not stop there. And all stakeholders have a role to play in helping to develop solutions. We're committed to working with the subcommittee, members of Congress, and other stakeholders on this important public health issue. Thank you.
Thank you. Mr. Mayor?
Madam Chair, Ranking Member Butterfield, and Mr. Lance, I appreciate the opportunity to appear before you today. I'm here today representing MedReturn. MedReturn is a subsidiary of Frank Marin Associates, an 80-year-old family-owned company in Grafton, Wisconsin. Our core business is designing and manufacturing in-store displays, merchandisers, and interactive kiosks for Fortune 500 companies. Our involvement in the issue of prescription drug abuse stems from the commitment to provide a safe, secure, sustainable, and environmentally friendly way to help law enforcement agencies and communities collect unwanted or expired prescription medication and over-the-counter drugs. The genesis of MedReturn began over 3 years ago when I challenged the associates in my company to research and develop new ideas. The challenge was called WIT. Wish I'd thought of that. As we began investigating the prescription drug disposal issue, we quickly became aware of the magnitude of prescription medication and drugs that sit unused or expired in our medicine cabinets. We began researching and looking for existing take-back programs and realized there was no consistent method or program available. Over a 2.5-year period, we developed, prototyped, presented, tested, improved, and produced the MedReturn Drug Collection Unit. Noting the importance of education, we incorporated a sizable graphic panel that states and communities can customize. We launched MedReturn at the International Association of Chiefs of Police Conference in October 2010. To date, our drug collection unit has been placed in 50 police and sheriff's departments across 11 states. We helped implement only the second county-wide ongoing drug collection program in the U.S. Attached statements from law enforcement agencies confirm the positive response of their communities to sustained drug collection. Lieutenant Tim Doney of the Medford, Oregon Police Department notes usage of their program is so heavy they are emptying the collection unit at least 4 days a week. Other email feedback we have received illustrates the demand for permanent medicine return programs. Sheriff David Peterson of Waushara County, Wisconsin reports collecting 200 to 250 pounds of medication in 3 months, and Lieutenant Wayne Strong believes the Madison, Wisconsin Police Department has collected 230 pounds in that same time frame. What started as an effort to supplement our core business has quickly evolved into a passionate desire to be a small part of the solution to the prescription drug abuse problem. We have devoted and continue to devote significant amounts of time and money to let state and local law enforcement agencies and community groups know we are available to answer inquiries. We know the DEA is working toward finalizing regulations that implement the Secure and Responsible Drug Disposal Act of 2010. We have talked with hundreds of law enforcement officers. Many of them are asking us how to implement their programs. Others believe the collection and disposal process is too complicated. Others insist on recording and inventorying all collected medications, and others don't realize the scope of the problem. We believe a lack of understanding may be a deterrent to establishing a permanent take-back program. We also find a varied interpretation of what constitutes safe disposal. Some departments accept pills in the bottle, while others want pills placed in plastic bags. Others will hold the collected contents until the annual take-back day. One officer admitted he collected the drugs but then flushed them down the toilet. Ideally, we would like to refer potential users of MedReturn to a central resource that outlines federal and state requirements and best practices. At MedReturn, our vision is a sustainable, nationwide program as widely available as plastic, glass, and paper recycling are today. By our calculation, there are some 30,000 communities that could benefit from a take-back program. We're in the process of seeking corporate or foundation partners that might speed this process. We appreciate the amount of attention prescription drug abuse is receiving from members of Congress and the administration. We hope you will continue to consider the challenges of those who want to establish a sustainable drug collection program at the grassroots level. We stand ready to serve as a resource in any way that is appropriate. Thank you.
Thank you, Mr. Mayor. Mr. Coyne? Please remember to turn your microphone on.
Good morning, Madam Chair and distinguished members of the subcommittee. It is a great honor that I testify today regarding pain management and the potential implications for patients in need of pain relief from diagnosis to survivorship. My name is Patrick Coyne. I've been a clinical nurse specialist for over 25 years, focusing on pain management and symptom control, typically in cancer patients. I'm the clinical director of the Thomas Palliative Care Services within the Massey Cancer Center at Virginia Commonwealth University in Richmond. In my role, I care for individuals on a daily basis who are dealing with life-limiting diseases and significant issues with pain. The patients I care for are from all walks of life, living in both urban and rural areas throughout the Commonwealth. I also teach in the schools of nursing and schools of medicine in our university and beyond. Today, I represent the Oncology Nurses Society, ONS, the largest professional oncology group in the United States, composed of more than 35,000 nurses and other healthcare providers. I would be naive not to recognize that the problem of opiate diversion is a very severe one and can destroy both patients, families, and communities. More must be done to treat this significant issue. However, what about those patients who live daily with intractable, unrelenting pain? Daily, I encounter patients who will not see their next birthday and often travel hours to see someone within our institution for appropriate analgesia because their local healthcare provider is uncomfortable with prescribing the medications the patients need or fearful that their license may be revoked for using too much opiate pain medication. This population of patients is frail, dealing with countless issues, which I hope I never have to, and often has no voice. I hope to be their voice and ensure their comfort. I also wish to support their privacy so that nobody needs to know about their illness unless they choose to release this information. The challenges within pain management are many. Individuals respond differently to different medications, including oxycodone. Many clinicians receive far inadequate training in prescribing analgesics, assessing pain, and other treatment options, and have false concerns regarding the role of analgesics. Certain areas in this country have limited resources for managing pain well. We know adequate pain management, as demonstrated in several studies, can increase both survival and quality of life for patients with life-limiting diseases. Caregivers often suffer from depression and financial impact when pain is poorly controlled. Pain is a serious and costly public health issue. Unmanaged pain is a tragedy. What really seems to be the tragedy is the patient population, this patient population may suffer because of those conducting illegal activities. Pain management is challenging in any population. Cancer patients fear pain, as do their families. But what of cancer survivors who suffer daily in pain but are disease-free? Consider those individuals from pain from poor cardiac output, sickle cell disease, or burn injuries as examples of just a few populations of patients who may be at risk without the availability of certain opiates. Addiction and misuse of analgesics is exceedingly rare in patients in pain, yet they may carry the burden and suffer the decision made by others. All discussion about the issue of opiate pain medications need a balanced exploration of the risks, but also the benefits of the medications when used appropriately. Limiting a pain medication, any medication, might take a very safe option away from countless patients living with moderate or severe pain. Education of prescribers is clearly needed to better assess pain and implement appropriate treatment options, but limiting options may ruin many individuals' lives. I have treated many patients with oxycodone, OxyContin, and other analgesics, mostly cancer patients, who have not tolerated other medications or did not get adequate relief from other opiate or non-opiate pain medications. Patients and their families need better education and support regarding the safe and appropriate use of, storage, and disposal of medications. The needs of countless patients suffering in pain need to be part of this and any discussion. I want to thank you for your time and commitment regarding this exceedingly important subject. I've devoted my life to pain management, and I fear that many patients I care for may suffer if poor decisions are made regarding pain management, and I welcome your time and questions. Thank you very much.
Thank you to all of the panelists for your expert testimony. I think, Mr. Coyne, first of all, I applaud you in your efforts and think that we share the same goals. My father was suffering from last stages of cancer just a couple of years ago, and I watched him go through it, so I appreciate what you see in a clinical setting. But at the same time, I've seen people suffering from opiate withdrawals. And so I, too, care about those people and the pain that they suffer and the life of living with that addiction. Once you're an addict, as you know, you're an addict for the rest of your life. So hopefully we can continue to work to make sure that the people who you need to treat are treated to the best of your ability, and we can also keep the hands out of the drugs out of the hands of the bad guys. And it goes to Ms. Martello. I keep hearing this reoccurring thing that it's coming from friends and family and medicine chests. And I can't believe that y'all are serious when you think that's the big problem. You know, just this week there's an article about another prescription drug sting with 15 arrested in San Diego, California. Now, I will grant that they were arrested because they had prescription pills that they didn't have prescriptions for, but they also had cocaine, methamphetamine, and other street drugs. But can we take our head out of the sands and quit acting like it's all grandma's medicine chest and admit the fact? And let me just go to Dr. Koster. You are a licensed pharmacist. In 2008, the Partnership for Drug-Free America, or drugfree.org's president, Steve Passerb, and he's Steve Passerb, he said in a Reuters interview that, and I quote, "OxyContin is pharmaceutical heroin. There's really no difference between the two." Do you care to explain the difference pharmacologically between OxyContin and heroin, how far off it is?
To be honest, Madam Chairman, it's been so long that I've been in pharmacy school, I'd probably get it wrong if I did it. So if you'd like, we can provide you an explanation after, but at this point, I probably wouldn't be able to do it in a way.
Well, it's my understanding it's one molecule off. I mean, that would be a fair characterization, and you certainly can submit that to me in writing later. But would you say that OxyContin and heroin, as consumed, the way they are consumed by the human body, the only difference is the delivery mechanism?
Again, I wouldn't be able to comment on that. From a pharmacological perspective, I wouldn't want to give you any incorrect information or inaccurate information. So, again, if you'd like, I'll be happy to provide whatever I can in writing after the hearing.
Well, it's my belief and my contention that they are pretty darn near the same. But to both you and Ms. Martello, you keep using under adherence and medication noncompliance and those terms in your testimony. When you talk about the problem with under adherence and noncompliance, are you lumping in therapeutics, antibiotics, other drugs into that category? Can you really say that there's a problem that people are not taking all 30 days of OxyContin when they're prescribed it?
I think appropriate use of medicines can go a long way to helping patients improve their health conditions. And as I said in my testimony,
including 30 days of OxyContin.
This is something that I think, as we've heard throughout the testimony this morning, there are a variety of stakeholders who have a role to play.
Now, let me get back to this. It's a simple question. Are you saying that it's for the patient's benefit that they take 30 days worth of painful painkillers like OxyContin?
I think healthcare professionals are on the front line of this every day, and I think part of the educational effort that we can engage in.
No, this is like a yes or no. This is a yes. This is and to Dr. Koster too. It's a yes or no.
I mean, I can give you a personal experience if this helps. I had surgery a couple years ago, and when I left, the physician said, "Here's a prescription for," I can't remember if it was 30 or 50, for OxyContin. I went to get it filled, and he said, "If you need them, take them." So I guess he thought that in my case I might need 2 or I might need a week's work. So I think, and again, not to justify how these drugs are used, but some people, I guess some physicians feel like, I'll give you this quantity, and if you need them, take them. If you don't, they don't really tell them what to do with them. So I don't know if it's a yes or no answer, but in terms of a personal...
No, the question is extending their life, extending the quality of life. You're lumping this in, it seems to me, with therapeutic drugs or antibiotics or something when you talk about under adherence of drugs.
Well, I mean, again, in terms of, like, if you're taking a blood pressure medication where you absolutely have to take it every day, or you have a cholesterol medication...
But we're not focused on those drugs today.
No, I know that.
But we keep saying it, under adherence, under adherence.
I think in the case, and again, I'm not a prescriber, but in the case of pain, oftentimes you get prescribed a quantity of medication because the physician doesn't know, for example, how you're going to tolerate a certain procedure. He might say, you might need these for 5 days, you might need these for 10. Again, I'm not justifying this. I'm just saying, and as a pharmacist who's seen a lot of patients come in and fill prescriptions for pain, where the patient says, I may not need all these, or why did the doctor give me all these? You're trained to tell the patient that the physician probably gave these to you because he's not sure how many you're going to actually need.
Well, my time has expired, but we'll come back to that, and I'm sure Mr. Mayor is very appreciative of the overprescriptions because he's Mr. Butterfield, you're recognized for 5 minutes.
Chairman, as we have heard 70% of non-medical prescription drug users get those drugs from family or friends. It can be given to them, it can be sold, they can actually, unfortunately, steal it from others. We also know that the family medicine cabinet is bulging with unused and no longer needed medicines. Disposing of these medicines properly must be a priority, and we must work to reduce their negative impact on the environment. When people do not have a safe place outside of the home where they can dispose of their unused drugs, they typically flush them, causing them to ultimately end up in our waterways. Question: I understand that a number of communities have created take-back days in which medicines are safely collected by law enforcement. Also, the Secure and Responsible Drug Disposal Act, sponsored in the House by Mr. Inslee of Washington, will allow more people and places to collect these unused medicines. This question is for Mr. Clarkin. Does the partnership that you represent have any examples of times when a take-back operation works particularly well?
Not specific instances in specific communities, but we, first of all, support the whole take-back program that the DEA has spearheaded, and the most recent take-back initiative, I think it was pointed out earlier, was terrifically successful in terms of the quantities of drugs that were actually brought back and safely disposed of, and we look forward to supporting the DEA at the April 30th take-back.
Thank you. Next to General Dean, thank you for your service to our country. What branch were you a part of? All right. Ever stationed at Fort Bragg? All right. According to, and thank you for that, according to reporting by the North County, California Times, almost said North Carolina, the North County, California Times, a couple of years ago, military doctors wrote service members nearly 3.8 million prescriptions for pain medications, up from less than 900,000 10 years ago. The Defense Department estimates that abuse of prescription drugs in the military is double that of the general population. First of all, do you agree or disagree with that? That military drug abuse is more and probably twice as much?
Excuse me, General, would you please turn your microphone on?
Okay, back.
Thank you.
I agree that the military has a significant problem with this issue. I don't have the exact statistics on it.
But you have no reason to disagree with that statistic.
I have every reason to agree with that.
All right. And it appears that one study in 2009 even found that 20% of Marines had abused prescription drugs, mostly painkillers, at some point in the previous year. Our active service members face significant anxiety overseas, and many live through pain every day when they are on duty. But if they develop a physical dependence or addiction to prescription drugs, it can follow them back home to their civilian life, and I have seen it all of my life. General, what should the administration do with regard to training veterans hospitals to be on high alert for this type of abuse?
I think it's a multifaceted approach that needs to be taken in order to assist our military members and their families in the communities that they reside in. I've had some discussion, my organization has, with the Army. I have another meeting scheduled with them in the very near future to address just this issue of helping them be more holistic in their approach of dealing with this issue that is not only social focused, but also for the family members as well as the other civilians as well.
Are there other programs? Yeah, I have about 40 seconds left. Are there other programs geared to prescription drug abuse by veterans? For example, veterans may receive health insurance from the federal government. Are the insurers instructed to be on the lookout for abuse, and not simply for the sake of law enforcement, but really to help the veteran?
The answer is yes. I have a board member who runs the VA Substance Abuse Center of the big VA facility in Atlanta, Dr. Karen Drexler, and the VA has programs, but the resources and the number of people that they have, in my opinion, I'm not speaking for the VA, needs to be expanded, and there needs to be greater information provided, and there need to be greater educational programs. But do they have the programs? Yes, but my understanding would be that there needs to be a substantial enhancement in those programs.
Thank you. Thank you, one and all. I yield back.
Thank you, Mr. Butterfield. The chair recognizes Mr. Lance for 5 minutes.
Thank you very much, Madam Chair, and good afternoon to you all. I find this testimony very interesting. I don't have the honor of representing Fort Bragg, but I do represent the district in the United States that has more medical and pharmaceutical employment than any other district in this country, and certainly this is an issue in the district as well as across the country. To Dr. Coster or to Ms. Martello, or to both of you, regarding the risk evaluation and mitigation strategy at the FDA, based upon your expertise, do you feel that it has contributed to the mitigation of prescription drug diversion? And has there been any unforeseen consequence, such as access issues for patients?
When we look at policies in this area, certainly balancing the need between legitimate patient access and ensuring that the product's benefits continue to outweigh its risks is an important public health consideration, and I think that those are the issues that are currently being grappled with. The FDA has a variety of tools in its arsenal to make sure that the product continues, the benefits continue to outweigh the risks of any product.
Dr. Coster?
Yeah, sure. That's an excellent question, Congressman. There's so much focus and attention that's been placed on this program, and even though it's not yet been fully implemented by the FDA, I think just by the attention it's received, it's caused physicians to maybe look more closely on how they prescribe and patients on what they do in terms of taking these medications. But I agree with Ms. Martello that any program put in place like this should assure that it doesn't interfere with the appropriate prescribing of these medications, the appropriate dispensing of them, and that patients in pain are able to get them. And I think the agency itself is struggling with what that right balance is right now for these extended release and long-acting opioid products.
Thank you. And to Ms. Martello, you state, and I agree with you, that you do not want to see barriers to patient access for needed prescription medicines. You highlight one potential barrier could be unnecessarily restrictive drug control regulations and practices. Could you give us in a little greater detail what you mean by that?
I think healthcare providers play a pivotal role in helping to ensure that patients have access to the medicines that they need, and so we'd want to have healthcare providers and pharmacists, frankly, to be part of this conversation to help ensure that they can work with patients and counsel them on medication management and using the medicines appropriately as prescribed.
Thank you. And to General Dean, first of all, thank you, sir, for your service to our nation. Have you seen greater abuse given the fact that we now have military operations in the field in both Iraq and Afghanistan? And has there been a tracking of this in relationship to other times when we have had our military personnel in combat situations?
As you know, I've been retired for a few years now. So
yes, sir.
I'm giving you information from my perspective and not from within the Department of Defense. But clearly, the protracted wars that we've been in and the extensive number of severely wounded soldiers and other members of the armed forces have contributed to an increased number of them needing and benefiting from over a long period of time for these medicines. And as a result of that, it is clear, and my friends have told me, that there are an increasing number of them who unfortunately are now abusing them. And they are trying to find ways to combat that. Just recently we had an officer as senior as a 3-star general admit that he was addicted to painkillers, pain medicine. So it is an issue. I'm not actively involved in it now. I'm looking to work with the military services to help them build some procedures that would get at training and education around military bases that would help combat this. But it is a significant issue.
Thank you very much. And Madam Chair, I yield back my remaining 4 seconds.
Thank you for your generosity. Recognize myself for 5 minutes again and say that it's so unfortunate, General, that we're hearing that this is truly carrying over into our troops, and it just really makes a huge punctuation point on how important it is that we're doing this here today. So I thank you for your testimony and for being here. Quickly, just to point out, though, that the FDA does not currently have a REMS program for long-acting and extended-release opioids. So it is not currently in place, and I am wondering how long it will take for them to do it and how many deaths will it take for them to do it. And I'm curious, you know, fen was taken off the market really quickly. If either one of the two pharmaceutical reps can explain to me the difference, why fen would have been removed from the market, or some of these drugs that are so quickly, and what the difference is between that and these opioids that are now up to tens of thousands of deaths a year.
It would be inappropriate for me to substitute my judgment for that of the independent scientific expert agency, the FDA, which evaluates the safety and efficacy of all marketed medicines. And so from my perspective, I think it would be inappropriate for me to comment on that.
Okay, fine, then let's move. Let me use my time with somebody who can actually comment, if that's all right. Mr. Clark, and any of you, can you explain to me why the abuse of opioid drugs became a problem so quickly? The trend lines screaming up there. Anybody who's out there in the field, in the real world?
I mean, I think there's probably a combination of factors, and clearly supply has been a factor. I think the environment of marketing, direct-to-consumer marketing in the pharmaceutical industry has expanded the abuse of prescription drugs, not just prescription opioids.
In fairness, I have never seen an advertisement ever for OxyContin.
That's correct. But my point is that the direct-to-consumer advertising, and I think there's a fairly robust literature on this now, is creating a sense of a reliance on medicine to address a variety of different ills. And so we see in our research, which I mentioned, and Dr. Boyd sees the same thing, an increasing reliance on the part of teens, at least, to be addressing not just to self-medicate or recreate with these substances, but to address life management issues. And I think that is linked in some measure, not entirely, but in some measure, to aggressive marketing.
Thank you. Does partnership have any explanation, just from observing standpoint, of why rogue pharmacies specialize in hydrocodone versus oxycodone or other controlled substances, yet the pill mills specialize in oxycodone instead? Has anybody figured out that discrepancy?
I don't have an answer for you on that.
Anybody know that answer? Okay. Mr. Mayor, the Take Back program, what do you see as the key features of a successful, always available program?
Local community support, education is going to be the biggest key. Letting the communities, the public, know that there is a sustainable take-back program within their community. The program that we put together, the countywide program, which is in our county actually, was a combination of news media and support from local newspapers, but it was also putting flyers in the pharmacies, letting individuals know when they pick up their prescriptions that they can dispose of unused, expired at the local law enforcement agencies.
Terrific, thank you.
Education's the key.
Okay. Dr. Koster, when you see the statistics and graphs that Governor Scott presented earlier showing the disproportionate share of drugs dispensed from Florida and national statistics on drug diversion, do you think that the DEA and FDA quota system needs to be reevaluated in light of the high percentage of diversion, particularly in Florida?
Well, I know the way the quota system, I know the way the quota system works now. It's based on I think a combination of factors, both in terms of what the data show in terms of demand, FDA data and other data that feed into DEA, and then DEA then determines how much our individual manufacturers can make. In terms of the situation in Florida, it sounded like part of the issue down there was that they didn't have a prescription monitoring program, which hopefully that will, deter some of the abuse. But I mean, we're happy to talk with the committee and the DEA about whether the system needs to be recalibrated.
Let me just back that out. I'm sorry, I'm down to my last 15 seconds. You just said the quota is based upon the demand?
No, I understand that, but
isn't that the problem here? The quota, are they, if anybody wants it, then they're allowed to make it. That's as simple, that's it? That's the way you just explained it.
Well, again, I'm not intricately familiar with how the DEA determines its actual quota, so I just gave you a broad overview. So as I said, maybe it's time that, that whole system is looked at again in terms of how those quotas are determined based upon what's happening in the state.
Thank you, Doctor. All right, Mr. Butterfield, you recognized?
Thank you. Let me drill down on prevention for just a moment, if I can. If we can prevent abuse, we know we can save millions of dollars, and more importantly, we can save many, many precious lives. As prepared by the Office of National Drug Control Policy, the 2010 National Drug Control Strategy calls for federal, state, and local entities, as well as non-governmental partners, to seek early intervention opportunities in healthcare. One of the opportunities that the strategy highlights is working with physicians to achieve consensus standards on opiate painkiller prescribing. Mr. Clocklin, I'm going to go back to you. What do you believe are the best ways to seize this opportunity? How specifically should stakeholders unite around consensus standards? For example, should task forces or working groups that include doctors, nurses, pharmacists, and others be created? What role can the partnership play in such a process?
I think we've heard a lot today pointing to the need for prescriber education, first of all, on appropriate prescription of opioids and other medications. One of the measures that the partnership supports is the explicit linkage of education of prescribers to their DEA registration renewal every 3 years. So we believe that's an important piece, and it's one that Director Kurlikowski also cited when he spoke here earlier. I think the dialogue, too, between healthcare professionals, whether they're prescribers or pharmacists, the dialogue between those healthcare professionals and consumers, particularly parents, needs to be much more mindful of the risks of abuse, the risks of addiction. And I know one of the pieces that's under discussion as part of the long-term opioid REMS and one that the partnership supports, is the adoption of effective prescriber-patient agreements at the point of prescription, so that the patient very clearly understands the risks. First of all, there's a screener so that the doctor is aware if the patient indeed is particularly susceptible to addiction, but the patient is also aware of the risks of abuse, the risks of addiction, and the need to effectively safeguard meds, dispose of them appropriately.
Yeah, perfect timing. We've just been called to the floor. You heard the buzzer. I'm going to have to yield back. Thank you.
I thank the gentleman, and does the gentleman from...
I do not, Madam Chair, have any more questions. I yield to you.
I thank the gentleman for yielding back, and believe that we should wrap this thing up. Before I do, I'd like to ask unanimous consent that these 4 items that we have previously discussed with the minority be included in the record.
No objection.
I thank the gentleman. And we also have statements from members who are not on the subcommittee that will be submitted for the record without objection. And so I just wanted to say that as we wrap things up today, I want to thank all of our panelists, as well as my colleagues and their staffs, for their time and the commitment to this critically important issue. If 30,000 Americans died every year from food poisoning, Congress would take action. If 30,000 Americans died from pesticide exposure, Congress would take action. And if 30,000 Americans died in airplane crashes every year, trust me, Congress would take action in a huge way. So why are the victims of prescription drug abuse treated differently? I don't have an answer, but I encourage everyone here to help us find one. I remind members that they have 10 business days to submit questions for the record, and I ask the witnesses to please respond promptly to any questions they receive. Again, I thank you all. I look forward to our work together in the future. The subcommittee hearing is now adjourned.